Thank you very much for the organizers to invite me to give this first Professor David Cooper Memorial Lecture. It's also difficult to do it because I'd rather have that I didn't have to give this lecture, but I'll try to give the lecture and do my best. What I decided to do is really to make it a personal tribute to David, as what I've called David being a key architect of the antiretroviral treatment odyssey, and I'll explain that in a minute. Wait a minute. This is not... I need to get this... See if this works. The arrow doesn't seem to be moving. Can you give me the next slide, maybe? Yeah, fine, thank you. So these are my disclosures. And what I'd really like to do is that as a tribute to David and Dory's Eastern European Jewish heritage, I am going to illustrate my remarks with sections of Marc Chagall's Mosaic, which is in Nice, and it shows the travels of Odysseus as described in Homer's Odyssey. And thereby, I want to pay tribute to David's endeavors in developing antiretroviral therapy as we know it today. David was a leader in designing and conducting antiretroviral randomized clinical trials, and really a collaborator pur sang. He also was visionary throughout his career, as illustrated actually by these two early trials from the late 80s, conducted by the European Australian collaborative group. Can somebody help me maybe with the... Can somebody help me maybe with moving the... There's something that I need to get moving. I need some technical help here. Okay. Anyway, this is what you see here is on the left is an early trial an attempt at early treatment with zidovudine monotherapy, and on the right is a trial which looks at early attempt at combination therapy with AZT and acyclovir. And in that trial with AZT and acyclovir, let me see, go back for a second here. Actually, they made a very interesting observation in the sense that the benefit was only shown after 4 weeks, whereas in the first 4 weeks, there was actually an increase of OIs, and this was really a very early signal of what we later came to know as IRIS. Clinical benefits in terms of reducing disease progression and mortality were subsequently demonstrated with dual nucleoside therapy in the Delta trial, shown on the left, and in the Caesar trial on the right, for which David served as the corresponding author for the publication in Lancet. And although Caesar did have patients on an early type of triple therapy, including dual NRTIs plus the NNRTI lovoride, we of course learned that the observed benefits were transient, as many patients were harboring NRTI-resistant virus and were in fact receiving functional monotherapy with an NNRTI, which then again selected for resistant virus. But not long thereafter, as novel NNRTIs and the first protease inhibitors arrived, and PCR technology gave us HIV RNA to better measure what our treatments were actually doing in patients, the promise of triple therapy began to dawn in the mid-90s. One of the early examples showing the potency of triple therapy was the INCAS trial, again involving David, demonstrating how triple therapy with AZT, DDI, and nevirapine could result in sustained suppression of viremia. And the clinical potency of these triple regimens was shown, for example, and I'm showing that on the right, by the truly miraculous effect they could have on patients with crypto or microsporidial diarrhea, complications of HIV which until then actually had been untreatable. David and his team in Sydney soon reported the remarkable impact that the availability of HAART had in Australia, showing 43% fewer AIDS cases and 80% fewer deaths in patients having reached a CD4 count below 200 in 1994 compared to those who had reached the same threshold in 2000. But the downside of early HAART was also soon recognized. David, together with Andrew Carr, were the first to report their astute clinical observation, another characteristic of David, a very astute clinician, in patients of changes in body fat distribution or lipodystrophy syndrome. And actually, I was discussing just now with Andrew Hill, the next speaker, that issues like these may be coming back at us, and it's too early to say, with the integrase inhibitors in the current era. Although the sole culprit for the lipodystrophy syndrome was initially thought to be the newly introduced class of PIs, with David and Andrew proposing a possible mechanism explaining the hyperlipidemia, insulin resistance, and fat accumulation shown in this study, they and others, including Simon Malal's team in Perth and our own team in Amsterdam, subsequently realized that lipoatrophy was the true culprit of the syndrome, and that in fact the thymidine analog, stavudine, with zidovudine having a similar but weaker effect, were the drugs to blame. The Sydney team, in their characteristic fashion, then went on to perform the seminal trial to show that discontinuing thymidine analogs and replacing these by abacavir could halt the progressive loss of subcutaneous adipose tissue and partly reverse it. What became increasingly clear early in the new millennium was the global inequity in access to ART and the need for global solidarity in changing that situation. And so it was that the vision of the HIV Netherlands, Australia, Thailand collaboration was conceived during a meeting between Professor Prapan Panupak, Professor Joep Lange, and Professor David Cooper in November 1995. They discussed the need for more affordable HIV treatments in Thailand and other resource-limited settings, and the reluctance on the part of the pharmaceutical companies and other sponsors to move HIV-related clinical research to areas where HIV is most prevalent. They concluded that a multi-center clinical research organization should be established in Thailand to address these issues, and HIV-NAT was founded, and the first study began enrolling patients in September 1996. These are the first examples of the randomized clinical trials at HIV-NAT, which started to address whether lower doses of the dual NRTI combinations available at the time could be used in a low body weight Thai population. These studies also set the stage for the setting up of a PK lab within HIV-NAT with the help of David Gerger's group. And although dose reduction in these early trials led to worthwhile suppression rates in general, this type of strategy was pursued in the current treatment era and shown to be successful in the LASA trial, shown on this slide. In this study, switching virally suppressed patients to a lower dose of atazanavir was found to be non-inferior to using standard dose atazanavir. Not only could such a strategy result in less toxicity, but also in saving cost. And in the discussion of the paper, the investigators concluded that if all 20,000 patients, and this was at the end of 2014, on second-line protease inhibitor-based ART were switched to atazanavir 200 instead of 300 milligrams, the cost saving for Thailand would be about $102 million over 5 years. As I mentioned before, with the establishment of HIV-NAT, David, together with Joep Lange and Prapan, wanted to contribute to bridging the divide in the global inequities in access to ART. Not surprisingly, this was also the title of an editorial David and Greg Dorr wrote for the Medical Journal of Australia in 2001. They felt that Australia had a responsibility in doing so and wrote, "If the challenge of the past decade was to develop therapeutic agents to control HIV infection, then the even greater challenge of the current decade is to provide access to effective HIV treatments for people in resource-poor countries. And they went on to state, if the HIV/AIDS treatment divide between industrialized and resource-poor countries is to be bridged, we urgently need Australian research, medical, and educational institutions to become more involved and public and private sector funding to be enhanced. And I would think that you agree with me that that's exactly what they've done. David's leadership and that of others in his team, of whom I'd like to specifically mention Sean Emery at this time, was instrumental in taking that responsibility forward, in expanding the work that the National Center and subsequently the Kirby did and continues to do in performing large-scale trials of innovative strategies, several of which have influenced treatment guidelines. An example is shown here, the ENCORE study, which demonstrated that the non-inferiority and decreased toxicity of reduced versus standard dose efavirenz, and this was a study, mind you, conducted in 38 sites across 13 countries on 5 continents. The primary 48 weeks results of which were published in The Lancet in 2014, and after the durability of this strategy, the 96-week data were published in Lancet ID the following year. This led to this regimen become listed as an alternative option in the WHO guidelines published in November 2015, talking about impact. And then, of course, there is the START trial, conducted by the Insight Group, which David helped establish, a trial with an important contribution from HIV-NAT as well. Fred Gordon, whose picture I'm showing, was another leader of the trial team and unfortunately passed away on the same day as David. START, once again, was a trial which resulted in guidelines changing across the globe, including those from WHO, and adopting the policy of immediate treatment initiation regardless of CD4 count. Here in green, you can see that this policy by mid-last year had been adopted almost universally, but the actual implementation still needs further progress in various parts of the world. So where has this all brought us? HIV-NAT has developed into a world-renowned research center which has conducted over 200 adult and pediatric studies on ART, on pharmacokinetics, on co-infections, on long-term complications, on sexual and reproductive health, and is expanding, as you just heard from Professor Papan, into areas like, for instance, tuberculosis, etc. It has yielded over 600 peer-reviewed publications and has resulted in numerous national, regional, and international collaborations. And also, and this is shown on the bottom of the slide, very recently in 2018, HIV-NAT has received due recognition for these achievements. Very recently, not only for recruiting, but also adequately retaining participants in the REPRIEVE trial, which is currently being conducted by the ACTG, and this trial importantly will address the question whether the use of pitavastatin, a statin, will reduce the risk of cardiovascular events in people with HIV without known CVD, at low calculated CVD risk, and without elevated LDL cholesterol, but of course with the chronic inflammation that comes with treated HIV. Our antiretroviral regimens not only have become more durably effective, but also increasingly better tolerated, as shown in this updated meta-analysis of trials by Andrew Carr and colleagues, which was recently published in AIDS. These advances are reflected in treatment guidelines across the globe, with preferred regimens shown in purple on this slide increasingly shifting towards integrase-containing regimens. Dual initial regimens shown on the right, without TDF or TAF or abacavir, such as, for instance, very recently 3TC plus dolutegravir, have shown non-inferior efficacy, at least over the short term, and have become attractive alternative options, for instance, in patients with underlying significant renal or cardiovascular disease. Last year, also, several novel fixed-dose combinations shown on the slide were licensed, as was the first monoclonal antibody, ibalizumab, for use as part of salvage therapy in heavily treatment-experienced patients with multi-class resistant HIV. Not only have several new drugs or drug combinations been recently approved, there also is a very active development pipeline of novel agents in clinical trials. I'm not going to go through all the agents listed on this slide, but just want to mention that these include drugs with novel mechanisms of action, like a range of broadly neutralizing antibodies being developed for either treatment or prevention, a nucleoside reverse transcriptase translocation inhibitor, and in phase 3, the attachment inhibitor fostemsavir, as well as long-acting formulations of cabotegravir for PrEP and cabotegravir plus rilpivirine for treatment. 2018 also was the year where the concept of undetectable equaling untransmittable, including in the setting of condomless anal sex, was definitively nailed after the presentation by Alison Roger at AIDS 2018 of the final part of the partner study. The social and societal importance of this study, as well as all the preceding scientific evidence underlying the concept of treatment and prevention, was eloquently expressed by NIAID Director Tony Fauci and colleagues in a paper published in JAMA just last week. And they state, the USU concept bridges the best of biomedical science with current concepts in behavioral and social science by removing the sense of fear and guilt that a person may be harming someone else, as well as the feeling of self-imposed and external stigma that many people with HIV experience. The impact of treatment as prevention is likely an important contributor to the decline in the estimated annual number of newly acquired HIV infections in my own country, the Netherlands, shown here in the dark blue line. Should this trend continue, the Netherlands is likely to achieve the UNAIDS goal of achieving a 75% reduction in the number of newly acquired HIV infections compared to 2010, and hopefully will be able to do even better once the availability of PrEP finally takes off in the course of this year. But in spite of all these advances, we must also realize that we still have miles to go and many challenges remain to be overcome. When looking at the global ART scale-up, it is an incredible achievement that approximately 22 million people are receiving ART, which has brought the global coverage to more than half, or 59%. But at the same time, it also means that as many as 15 million people do not yet have access. Thus, the inequity of access to testing and care, which I talked about before, continues to persist, and it is different in different regions of the world, as shown on this care cascade slide. And it continues to be fueled by structural barriers, including violation of human rights, gender inequality and gender-based violence, prejudices of various kinds, and lack of political will. Even in a country like the Netherlands, which now has achieved and surpassed the 1990 goals, important gaps in the continuum of care remain, as illustrated on this slide. Gaps which to a large extent will only be closed if we manage to overcome barriers to testing and sustained care for a variety of key populations with different cultural backgrounds, something that in my view will only happen if we do so in close collaborations with members of these different communities. Treatment safety also continues to present novel challenges. I have already mentioned how first-line treatment is shifting towards integrase inhibitor-based treatment. This slide illustrates the shift across the world towards dolutegravir-containing regimens, with countries depicted in dark green being the ones where dolutegravir was introduced in national guidelines and procurement had started as of mid-2018. But in 2018, we also learned about the results of the CEPAMO study. This is an ongoing birth outcome surveillance study among women with and without HIV infection in Botswana. The prospective design provided an opportunity to collect thorough data on drug exposure as well as the timing of exposure relative to conception and pregnancy. At an interim analysis, which has now been published in the New England Journal of Medicine, study investigators identified almost a 10-fold increased risk of neural tube defects when dolutegravir was used at the time of conception compared with the use of non-DTG ART at conception or dolutegravir used later in pregnancy. At AIDS 2018, updated data on a somewhat larger group of women exposed to dolutegravir around the time of conception was presented, shown in the yellow box on the slide. No additional cases beyond the initial 4 had been observed, bringing the NTD neural tube defect prevalence down from 0.94% to 0.67%. Although this reduced, this rate was still elevated compared with all other groups. The study continues, and the next formal analysis is scheduled for March this year. In the meantime, as I'm sure you're all aware of, guidelines have issued wordings and guidance for clinicians on how to respond to this safety concern in clinical practice when managing women who want to become pregnant or are pregnant. Another challenge for both patients and providers, which I would like to briefly mention, is one which is actually a testimony of our success with treatment. And this is that we need to take care of an increasing number of people with HIV with aging-associated comorbidities, such as those shown on the slide. And in many instances, the complexity of caring for these people is increased by the presence of multimorbidity. In these data, again from the Netherlands, one can see, for example, that as many as a quarter of patients in care over 60 now have 2 or more comorbidities next to their HIV. Thus, we will increasingly see the intersecting syndemics of communicable and non-communicable diseases, as eloquently discussed by Emily Heil during her plenary at AIDS 2018. And as you can see on this slide, which Emily kindly provided to me, there's ample room for improvement where it concerns the care cascades for a range of non-communicable diseases highly relevant to people living with HIV, such as diabetes, tuberculosis, and depression. In closing, I'd like to quote the Honorable Michael Kirby, who the Kirby Institute was named after, and who, when remembering David last summer in Amsterdam, said, "A great deal in understanding the very essence of David Cooper comes from understanding the world that Jonathan Mann created in the field of AIDS. We will remember David Cooper as a great scientist, a fine Australian, a kind man, a brilliant physician, and a very dedicated member of the IES, which does so much good in every corner of the world." Let me add to that David, like Jonathan Mann and Joop Lange, was a true human rights advocate, and we missed him. But at the same time, we need to celebrate that we have another human rights advocate, Professor Prapan Panupak, still among us. And it's therefore, I think, only very fitting that Prapan was asked to deliver the prestigious Ngali Mann lecture at the upcoming CROI conference in March. David's journey has come to an end, but thankfully we have a new generation of inspirational leaders who are there to uphold this legacy, and some of them, of course, are in this room. As David said at the end of his Ngali Mann lecture at CROI in 2015, we must finish the job, and it's the new generation that needs to do it. I'd like to end by letting you listen to David himself in this short video clip, which the IES kindly provided from a video which was made on the occasion of the 25th anniversary of the IES, in which past presidents like David provided their perspectives on the future.
For me, I think the biggest thing right now...
Can we have the sound?
Optimize the rollout. The donors are, I think, plateauing, and we've got more and more people to treat, and we have to work out how to do more with less money. or more with at least the same money. And for me, that's what's really exciting. What are the ways in which we can provide clinical science evidence for doing things more efficiently, more effectively, more cost-effectively? The cure issue is a complex one. I think the science is really important to work on that. I'm not sure that it's ready for, you know, putting potentially toxic drugs into people, and particularly when we have such effective antiviral drugs. You know, so and one of the other things that I think suffers in that is vaccine research. At the end of the day, I don't think antiretroviral therapy, as good as it is sustainable for life of a person. I'm not sure whether we'll eliminate HIV with test and treat. Haven't done that for tuberculosis, we've never done that for syphilis, so I'm not sure. And they're curable diseases, right? So I think that, you know, we have to be careful that we don't move to the next most exciting thing. And at the end of the day, I think a vaccine is the one way that will be a sustainable preventive strategy. That vaccines are the best things to prevent infectious diseases. As much as I've been involved in antiretroviral therapy, as fascinating as it's been, as the fact that I've been involved in every drug that's been developed at some level, whether it's phase 1 or phase 3 or whatever, and each one of those drugs has a personality of its own. As much as I think it's been a modern medical miracle, I think, yes, it'll be a mainstay of the way we approach the epidemic. I think the treatment as prevention has been a big advance to protect other people. But I still think that a vaccine is, at the end of the day, is the way to go, and we mustn't lose that momentum, as difficult as that is. Right?
Thank you very much for listening, and let's all treasure David's legacy and finish the job. Thank you very much.